I really believe this is going to focus our attention on improving that level of safety, that aspect of our safety. We're pretty good at everything else, but I think it's shown that it's a weak link.
Hey everybody, thanks for joining us again. I'm Mike Russ with ProEdge Dental Water Labs in Denver, Colorado, and I'm happy to be talking to my old friend Nancy Dewhirst. Nancy, how are you?
I'm doing great, thanks. How are you doing?
Hanging in there. We're all right. We're doing what we can. Hey, I got a question that's coming up a lot. How is COVID going to change infection control in general in dental offices coming out of COVID?
That's a complicated question. There's right now the interim recommendations to do dentistry only on emergency patients, but the cool thing about the interim recommendations is that they do explain what the real considerations are given what we don't know about this virus and about this situation. And it's forced us, I think, to look at general standard precautions. We've always known they work well for bloodborne diseases, for contact and droplet diseases. There's still a margin of risk there, but we've all accepted that. And we've always known that transmission-based precautions have to be used to manage aerosol transmissible diseases like SARS-CoV-2 or TB or pertussis or some of the things that we know are too risky to treat if you have an active patient. But the deal with this pandemic has been that you can't always tell who's infectious. You can't go by symptom screening like we can with TB. An active TB patient's going to have symptoms. They're going to have respiratory symptoms. They're going to have a fever. They're going to have things you can assess about them, and then you use that criteria and then you don't treat them in a normal dental environment because the normal dental environment can't protect us from aerosol transmissible diseases. So what this brought out is that many of us are concerned because now you've got 25% at least of the patients that can transmit this disease without having any symptoms. So you can no longer rely on symptom screening. Now you've got to implement some safety precautions that protect you when you don't even know for sure if you need it or not. So it brings up a lot of questions. Do I need to wear an N95 mask every day? What do I need? And I think we may have to change some of our safety standards, at least to be ready to implement a respiratory safety program in a dental office, whereas now most of us haven't even been trained to wear respirators. And we haven't thought that through. We've just sort of left that to the experts in medical facilities where they have negative pressure rooms and all that. So this forces us to, number one, look at the building that we work in, because we understand that there's sort of a hierarchy of infection control, that if you have a really safe building and you have good engineered safety devices and engineered controls in place, that you're safe when you walk in that door. They don't depend so much on you remembering to put your mask on. If you've got rules and regulations and administrative controls, you just have a policy where you don't treat sick people and you've informed them and you're assessing them and all the protocol in place. And last of all, if you've got a supply of respiratory protection equipment, let's just focus on that, to use, you can then select it and use it. So you've got this hierarchy of safety devices you need to be trained on, you need to have accessible, and you have to use. So long answer, I think offices are going to have to look at air exchanges per hour. They're going to have to look at filtration, maybe HEPA filtration of the air in the operatory, UV treatment of the air, anyway, the ambient aerosol management. Okay, that has to be looked at. Now that's assuming we all make aerosols, and maybe controlling the aerosol at the source better, using focused section. Dentists may use more rubber dams than they have in the past. In hygiene, of course, we can't with ultrasonic scalers. So we're going to be looking at aerosol generation, aerosol collection, air cleaning, respiratory protection to filter it so that we're protected at the closest to us, assuming it's going to be there. And then we're going to have to learn how to manage all those and juggle them and know when to use them and have them available. So I really believe this is going to focus our attention on improving that level of safety, that aspect of our safety. We're pretty good at everything else, but I think it's shown that it's a weak link. So.
And it's a whole new world then of infection, of a bunch of new protocols for infection control.
I think it is. I think it's a new world that way. I think we're going to have to look at it. I'm not saying the rules are going to change tomorrow, because rules take a long time to change. But we've got some key recommendations. We've got CDC recommendations, and then you have ADA recommendations, and they don't necessarily agree at this moment, but I'm sure they'll come together. And then you have states that look at it differently. So, recommendations set our professional standard. Regulations will follow, and we all have to find our comfort in which one of those we follow, or how many of those we follow, and how we integrate the guidance we're given and find a level of safety that we can live with. And right now, we just don't know as much about this as we'd like to, but it won't be the last pandemic to hit. It won't be the last respiratory risk that we encounter. So I think this is going to improve our chances of being more ready next time, being a little quicker to respond, have on hand the things we need, be able to grab them when we even suspect that there could be an extraordinary issue for us in the future.
Good stuff. Thanks, Nancy, very much. Let's do this again soon.
Okay.